Alrighty. Today's discussion will be about bacteriology stains, drug elimination, and wound healing. So, we will go ahead and start with bacteriology stains. Alright, so we're first going to talk about the Gram stain, which is the first line lab test in bacterial identification. So, this guy stains the peptidoglycan layer, and if your bacteria retains the crystal dye, it will be gram positive. If it has a thin peptidoglycan layer, it will turn red or pink, which is identified as gram negative. Yay, basics! Now there are some bugs that do not gram stain very well, and I left the little clue up there for everybody to see if you guys can name the bugs that do not gram stain very well.
Mycobacteria.
Mycoplasma.
Oh, damn it.
No, they're both right. Mycobacteria and mycoplasma.
Legionella.
Uh-huh.
Same telepathy today. Chlamydia?
Yeah.
Yes.
Rickettsia?
What'd you say?
Rickettsia?
Rickettsia.
Oh, sorry. Rickettsia.
I see a U there, maybe ureaplasma.
Mm-hmm.
Bartonella?
Yes.
What's that A for? Anaplasma?
Yes.
It looks like E.
Ehrlichios? No.
Okay. Ehrlichia.
Yeah, you're right.
We're just missing the first T and L.
Syphilis, treponema.
Yeah.
Mhm. And one more L.
He says Legionella. Listeria? I don't know.
Leptospira.
Leptospira. Okay.
So, what can you use for treponema, for example?
Dark microscopy.
Yes. And with mycoplasma and ureaplasma, these are generally unable to stain. As you can see, they don't have a cell wall, so can't really stain them. And with Legionella, Rickettsia, and all, you can use an immunofluorescence stain. Alrighty, so we will move on to the next slide, where there are some alternative stains or additional stains you can use to stain other things, as well as these bugs that did not gram stain very well. So I'm going to start by asking, what type of substance does the periodic acid shift stain?
Polysaccharides?
Yeah. You can remember it by past the sugar if you want, for glycogen and polysaccharides. What can it be used to diagnose? What disease?
Oh, this one's Whipple's disease.
Yeah, Whipple disease. And it is caused by what organism?
Whippley something.
Triferema Whippley?
Yes.
Yeah, that one.
That one. Trophorema.
Trophorema.
Yeah.
Trophorema Whippley.
Okay, now on to the Zeal-Nielsen stain. What kind of bacteria does this stain?
Mycobacteria? Acid fast, so mycobacteria?
Yes to both. So you can hit twice. And
Sorry.
what specifically, no, that's fine. What specifically does it stain in the cell wall?
This is the mycolic acid.
Correct. Nice. Alright, then we have India ink. And what organism does this guy stain?
Crypto.
Yep.
Crypto.
Cryptocards?
Yes.
Yep.
And what does it stain red specifically?
Outer capsule?
A thick polysaccharide capsule. And then we have the silver stain, which is used to stain what kind of organisms?
Fungi?
Yes. Okay. And can you give...
Legionella.
Oh, there you go. Legionella. There's your example.
Oh.
And what color does silver stain?
It looks like green in that little thing.
It's actually the black parts of
Oh.
silver stain stains the fungi black.
Oh. Good to know.
It's not really silver.
No. Alright, so any questions on that before we move on to drug elimination?
Yeah, why do you want to eliminate drugs? Huh?
Because you don't want them in your system forever.
Aw.
Alrighty, so drug elimination. It is the process involved in the elimination of drugs, shocker, from the body and their kinetic characteristics. There are 3 major modes of drug elimination. Can you guys name what they are? How are drugs eliminated?
The liver.
Liver.
Mhm.
Kidney?
Kidney.
Feces. GI?
Urinary? No, I have a kidney.
You can go ahead and click it. It's actually at the other category.
Ah.
Well.
That's what, yeah, you could probably exhale certain ones too.
And key concept for elimination is the elimination half-life. Can anyone explain what that is?
Like zero order or versus first order?
No. What
I
half-life
think that's what
is?
that last bar is.
What
So
half-life
a half-life is the amount of time it takes for 1/2 of the concentration of a drug to decrease in the body.
is? Correct. And as Yash had previously already given the answer to, there are 2 main types of drug elimination, with zero order and first order. So we are going to go ahead and start with zero order. So what is happening to the amount of drug?
It's getting excreted at a constant level, regardless of how much you're infusing, right?
Correct.
Yeah, so it's
Okay.
rate dependent.
Yes.
Okay.
So you have a constant amount of drug eliminated per amount of time. And, well, I was going to ask that, but too late now. The rate of elimination is,
Oh. I thought I already gave the answer.
that's okay, is independent
Well,
of,
because the other one is concentration dependent. This one is rate dependent.
yes. So this is independent of plasma concentration. So
Sorry.
it's okay. It's alright. Drugs with zero order elimination have what kind of half-life?
Constant half-life? No.
The other one.
Inconsistent half-life?
Yeah. They have a variable half-life or a non-fixed half-life. So, some examples of drugs with zero-order elimination. I've included the little clue there for you.
Phenytoin,
Uh-huh.
aspirin, and ethanol.
Yes. phenytoin, ethanol, and salicylates, and these are zero order depending on their levels. So ethanol is pretty much zero order except at very low blood levels. Phenytoin is zero order at high therapeutic doses, and aspirin and salicylates are zero order at toxic doses. So a little more specific category there. So then we'll go on to first order. Can anyone tell me what is happening with the drug in first order?
It's getting eliminated, like, compared to how much you've given, like, on the concentration basis?
How much of the drug is being eliminated?
Half of it, proportionally?
Well,
So
not
constant amount?
a constant amount, yes. So not necessarily half of the drug, but you're losing a
Okay.
constant fraction per unit time. And graphically, what will this look like?
A exponential curve.
Yes. So it'll look like exponential decay, and in zero order, it'll just look like linear decay.
Linear. Yeah.
So here, how is the rate of elimination related to plasma concentration?
It is dependent
Yes.
to the plasma level.
Yes. It's dependent, directly proportional. So the higher the amount, the more rapid the elimination. So we had our exceptions for zero order elimination. Pretty much everything else, mostly, follow first order elimination rates. So what is the half-life like here?
Constant?
Yes. So constant for first order elimination and variable for zero order. Alrighty. So this is taken from first aid, as you can see.
So when you talk about, like, constant per elimination, you're talking about, like, per time. Like, the half-life is per time, right?
Yes.
So, like, it's going to do it consistently at certain intervals, whereas in first order, it's going to do it, like, when the concentration is half eliminated. Or am I getting that mixed up? Like, based on looking at that graph, because it went from this concentration on zero order kinetics, right? So it went from the top to the next one, and that half-life is way longer than the next one.
Yeah.
So, but on the right side, it's constantly with the same amount of time. That's what you're trying to, I guess,
Yeah.
say.
So with first order, the half-life is gonna be the same no matter how much amount of drug there is. It's
Okay.
going to be constant. The half-life is always going to be the same. Versus zero order, kind of, the half-life depends on the amount of drug, but the rate of elimination is constant.
Okay,
So
gotcha.
it's either or. If the rate of elimination is constant, the half-life is going to be variable. But if the half-life is constant, then the rate of elimination is going to be a little changed by the drug concentration.
Gotcha. Thanks.
So, already talked about most of the stuff that you see on this page and also what it looks like graphically. What I want to talk about specifically is the capacity limited elimination that's noted under zero order elimination. And does anyone know what this is before I explain it?
Capacity limited elimination.
So,
No.
capacity limited elimination means that it's dependent on a cofactor. So drugs with zero order elimination, for example, if we take ethanol elimination is limited by the amount of NAD plus that is available in hepatocytes to be converted to NADH by the dehydrogenase enzymes. So this type of elimination is saturation based, so you can only eliminate by the amount of cofactor you have. So if all of your cofactors are saturated, it's just going to keep going at that same constant rate because of the availability of these cofactors. Does that make sense?
Yeah, so once you saturated the cofactors that help with elimination, then you're going to reach that constant rate, that zero order elimination rate?
Yes.
So is that why here you say ethanol except in low blood levels, because it's dose dependent because they all have cofactors which assist in the elimination?
Yes.
Oh, okay.
So once those cofactors are used up or they're highly saturated, then you hit the zero order elimination threshold, and then they all start going through that constant elimination. Cool. No. Alrighty. Okay, so a little practice question for you guys here. We have a 7-year-old boy comes to the pediatric clinic for the evaluation of sore throat and fever that have persisted over the last few days. This morning, his mother also noticed the appearance of a sandpaper-like rash on his neck and chest. A rapid strep test comes back positive. The boy started on amoxicillin, which follows first-order elimination. Which of the following statements describes characteristics of first-order elimination?
E.
Yes. Rate of elimination is proportional to the drug concentration. Awesome. And everything else is zero order.
Zero order? Okay.
Alright, so there's one other type of elimination that Kaplan mentions that I wanted to include is renal elimination. And they define it as the glomerular filtration rate plus active secretion minus resorption. Whatever, another equation in there, not really all that necessary. But renal elimination describes a type of filtration, and filtration is non-saturable and is linear. So it just happens, doesn't depend on cofactors that much. So then you have ionized and non-ionized forms of drugs, and these guys are filtered, but drugs that are protein bound are not. Makes sense. They're bound by proteins, they can't make it across. So then we have clearance, and clearance is the volume of blood that is cleared of the drug per unit time. A little weirdly worded, but the amount of blood that's cleaned off of your drug. And this is constant in first order kinetics. So a little comparison between clearance and the glomerular filtration rate. When these two are equal, what does that mean is happening to the drug?
The amount of secretion and reabsorption are equal and negate each other?
It's not getting eliminated?
Yeah. So they're either equal or there's no net resorption or secretion happening. And also, no plasma protein binding, apparently. So when clearance is less than the GFR, what does that mean?
Plasma protein is increased. Clearance is less than filtration. So there increase plasma
There's
protein.
more secretion than reabsorption?
The other one.
So more reabsorption than secretion?
Yeah. So when the clearance is less than the filtration rate,
Oh, less. Okay.
that means there's more reabsorption of the drug occurring, and yes, there could be more plasma protein binding because it's stuck in the body and not being cleared out as
Filtered.
much. But
Okay, but yeah, I see. It might be kind of more related to a different concept.
yeah. So if the clearance is greater than the filtration rate, now what does that mean?
You got active secretion.
Yeah. So the drug is being added to the filtrates, being secreted out of the system. Good riddance, good God. Any questions on this? It's a little weird topic here that's a little added in there, but
Well, this topic comes more in hand when you're talking about renal physiology, because this is a big one for, well, a lot.
Yeah.
That could be a whole other lecture.
yeah, so just Kaplan briefly throws it in there with drug elimination, so I thought I'd toss that in as well just to give a complete picture. So there that is. Alrighty. So back to first aid. Whoa. I talk about urine pH and drug elimination. So we talked about how we mentioned a little bit about ionized and non-ionized forms of drugs being filtered or not filtered. So ionized species are trapped in the urine and they're cleared very quickly, as it says over there, while neutral forms can be reabsorbed. So when we have weak acids or weak bases, if we ionize them in certain environments, they can be renally cleared. So, can anyone give me some examples of weak acids?
Aspirin.
Uh-huh.
Phenobarbital.
Yeah. And one more starts with an M. A little bit out there.
Magnesium. No.
Actually, methotrexate.
Yeah, not even close. I would not even have thought of that.
As I said, it's a little obtuse there, but that's okay. So we have phenobarbital, methotrexate, and aspirin as some examples of weak acids. And if they're weak acids, they can be trapped in what kind of environment?
Basic.
Basic. So if you overdose with any of these, what can you treat with to alkalinize the urine and trap them?
Like bicarb.
Yeah.
Yeah, we got that Wi-Fi going on today.
Yep.
Alright. Can anyone give me some examples of weak bases?
Yeah. I'm out.
One of them starts with an A, one of them starts with a T. They're described drug classes rather than specific drugs.
Tricyclic.
Yeah, so we have TCAs and something that...
Amphetamines?
Yes. We have amphetamines and TCAs as our first aids examples of weak bases. So if they're weak bases, they're trapped in
Acidic
environments. So what can you use to treat an overdose with these and acidify the urine?
Something chloride.
Yes. Ammonium chloride. Although this isn't really done anymore. Now they have different specific treatments, but this is what is theoretically done.
Historical.
Yes. Historically, theoretically, no longer done though, but just there as an example. So yeah, any questions on this before we have a practice question? Nope? Okay. So now we have a little practice filler in there for you guys. So phenobarbital and methotrexate are, were they?
Acid.
Yes, are acidic. And you can treat them with which of these?
Bicarb.
Sodium bicarb.
Sodium bicarb. And this will do what to the urine?
To alkalinize the PP.
Yes.
Oh.
Okay. So now we're going to move on to wound healing, unless anyone had any questions. That's fine. I will switch my books over here. Alrighty, so wound healing. So healing is initiated when inflammation begins. So you have an injury, got a cut, happens. As soon as inflammation starts, that's when healing is technically noted as starting. So healing occurs by a combination of two stages. Anyone know what these two things are?
Like remodeling? Is that what you're trying to ask?
So it can either do one of two things. It can either replace with more of itself or replace with a scar. And they're called specific words for these actions.
Like hypertrophy or?
You are... Well, you know what? I'm just going to say what they are. Because it might be a little hard for me to describe these. But you have a combination of regeneration, which is where you replace with yourself. And when you're replacing with a scar, it's called repair. Okay.
You're asking basic English.
Very, very basic. Yeah. Alright, so let's talk about regeneration. So we said this is replacing with self. You're replacing the damaged tissue with native tissue, and this depends on the regenerative capacity of tissue. So tissues are divided into types based on that capacity. And so we have labile tissues, stable tissues, and permanent tissues. So labile tissues have stem cells, and they continuously cycle to regenerate tissue. Can anyone give me some examples of labile tissues?
Skin.
Skin is one.
GI mucosa.
Yeah. One more, maybe.
Oh god, what's the third one?
I'll give you a hint. Something regenerates every 120 days.
Cells.
Yeah. So your bone marrow.
Oh.
Can anyone?
These are also reasons, just to chime in, why you see immunosuppression in chemo patients. Because these are our labile. So, like, because they get hit or through chemotherapy. So hence why, like, chemotherapy patients are going to vomit, have hair loss, and, like, dry skin, and, like, be immunosuppressed.
Because all the labile tissues are getting hit.
Getting hit, yeah.
Well, yeah, because I guess if you look at the chemotherapeutic agents, they're always hitting, like, whether it's, well, any kind of, like, the mitotic process.
Yeah. So if you think about it, these are using that cell cycle the most. They're constantly using it. So the ones that are using it the most are going to be most affected by the things that stop it.
Good call.
And a little bonus question here for you guys. Do you guys know the CD marker for hematopoietic stem cells?
Is it the same one, like 16, CD16?
Higher.
Never mind.
I just start guessing numbers, but I'm guessing we could go from, 16 to
34, yes.
CD34, alright.
Nice. CD34. Okay.
That was a guess, by the way.
It's a good guess.
Yeah.
Good guess. Alright, so now we have stable tissues, and these are the ones that can re-enter the cell cycle to regenerate tissue when necessary. Anyone give me an example for this guy?
Is it neural tissue?
There's a particular organ that can be...
Liver?
Yes, liver. So the liver is... Yes. The liver is the classic example. And regeneration can occur by compensatory hyperplasia after partial resection. So you resect the liver, it can compensate by hyperplasing. I'll pretend that's a word for today. Yeah. And then we have permanent tissues that lack significant regenerative potential, and there are 3 key ones that are characteristically known as permanent tissues.
Cardiac.
Cardiac is one.
Skeletal muscular.
Neural tissue?
Yes.
Oh.
Here we have our neurons, which, I mean, you might think axons have some regenerative potential, but again, it's not very significant. So,
bonus question: if a neuron is severed and is destined for repair, what part of the neuron needs to be intact?
Red
cell
or something?
Body.
Oh, dang.
So I'm thinking of the layers of the neuron. Was it the perineuron? Yeah.
Yeah, I think you're right.
Perineurium.
Yeah, that's the one.
So now we will talk about repair. This is where we are replacing with a scar. This occurs when regenerative stem cells are lost, such as when you have a really deep skin cut, or when a tissue lacks regenerative capacity, like myocytes after an MI. So, our granulation tissue is formed as the initial phase of repair, and it consists of what 3 things?
Macrophages?
The tissue.
Neutrophils?
The tissue specifically. What is the tissue made up of?
Oh. Fibrinogen? Or fibroblasts?
Yes. So we have fibroblasts. We have something that sounds like fibroblasts, but
Myofibroblasts?
there you go. Myofibroblasts, and then you have capillaries, whatever. So what do fibroblasts do?
They release some stuff.
They deposit some stuff. Particular type of connective tissue.
Some kind of growth factor? Fibroblast growth factor?
Collagen. And what type of collagen? Alright, well.
Type 3?
Yes. Deposit type 3 collagen. And what are capillaries useful for?
Oh man.
Something that starts with a P.
Blood supply.
And
Platelets? I don't know.
well, yeah, blood supply, yes, and the blood supply provides nutrients, so that's not. And myofibroblasts help do something to the wound.
Contract.
Yes, myofibroblasts will contract the wound. Nice job. Alright, so when we are forming a scar, what is replaced with what?
Type 3 to type 1 collagen?
Correct. So we have type 3 collagen is replaced with type 1 collagen. Awesome. So which one of these, type 3 collagen or type 1 collagen, is the pliable one that's present in granulation tissue, etc., etc.?
Type 3.
Wow.
Yes, type 3.
Oh.
And which one has high tensile strength?
Type 1.
Yes. And what enzyme removes type 3 collagen?
Collagenase?
Yeah. And what cofactor does it require?
Vitamin C?
Mm,
Zinc.
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 Alright.
Zinc.
Alrighty. So, a little bit on collagen before we continue on with repair. Type 1 collagen, where is it found?
Bone.
Yes.
Bone.
Correct. How about type 2?
Blood.
Cartilage.
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 Cartilage. And then 3 is blood vessels, right?
Yes. 3 is
Blood vessels,
blood vessels,
granulation
granulation tissue, etc., etc. And type 4?
Basement membrane.
Yes. Basement membrane. Type 4 on the floor. And then we have first aid's little image there too that I tossed in, pretty much saying the same thing. And then you can see what conditions you have associated with different types of collagen. Decrease in type 1, you can see in osteogenesis imperfecta. Problems with type 3, you can see in Ehlers-Danlos. And in type 4, you can see Alport syndrome and Goodpasture syndrome also. So, coming back to wound healing.
Oh boy.
So, wound healing is the tissue regeneration and repair is mediated by paracrine signaling using growth factors. And the interaction of growth factors with receptors will result in
Growth?
growth. So you will have gene expression
Oh.
and no, that's fine. Gene expression and cellular growth.
Oh, okay.
Alright.
You got part right.
So we're gonna attempt some examples of mediators and what they mediate. So TGF alpha. Does anyone know what growth factors this guy mediates?
Yeah, like the IL-1, IL-10,
6.
IL-6.
I don't know.
Are we on the right page? Are we in the right ballpark at least?
I'm looking for growth factors, not
That means a
interleukins.
no.
Not interleukins. For example, we talked about we see epidermal growth factor, we see I don't know, some other type of growth factor.
I have no clue.
Okay, well, TGF alpha mediates epithelial and fibroblast growth factor. How about TGF beta?
Fibrosis.
Close. So it also does fibroblast growth factor and is also useful in inhibiting inflammation. Then we have PDGF. What is this a growth factor for?
Platelets.
What's a platelet-derived growth factor?
Smooth muscles?
Yes. So it's a growth factor for endothelium, smooth muscles, and also fibroblasts, because we love fibroblasts apparently. How about FGF? What is this important for?
Tissues in general. Bone.
Something,
Yeah.
yes, for bone, but also for something that provides nutrients.
Blood vessels.
Yeah. So fibroblast growth factor is important for angiogenesis and, yes, also mediates skeletal development. And then we have VEGF. What is this guy important for?
Also angiogenesis.
Yeah, this guy is also important for
Ooh.
angiogenesis. Woo, we made it
Oh
through.
gosh.
Oh, man.
I promise it's not as horrible as it looks.
Mm-hmm.
Okay. A little bit more about wound healing. So we have primary and secondary intention. You guys know what primary intention is?
Form a plug?
So this is specific to cutaneous healing. So primary intention is when the wound edges are brought together. So this causes a very minimal scar formation. You're literally taking one end of the wound and the other end of the wound and bringing them as close as possible. So again, the point is minimal scar formation. So if
So this is like a paper cut.
So if that's primary, what's secondary?
I'm guessing this is more like an avulsion or something, where the wound is wide.
Yeah.
Wide margins.
Yes. So the edges are not approximated. They're not brought together. So what fills in that defect then?
Collagen?
Collagen.
Type 3 collagen.
Type 3.
First.
Yes. It's more generally granulation tissue is what I was looking for.
Oh.
Mm.
And then what component of granulation tissue we talked about contracts the wound?
Type 3 collagen?
Myofibroblasts
Oh.
contract the wound. And then this will form a
Scar.
Scar?
Yes. So primary intention, very minimal scar formation. Secondary, you're going to get a scar. Okay. There are instances in which wound healing can be delayed. There are a couple of examples, 3 specifically, in which...
Vitamin C deficiency?
Okay.
Copper deficiency? And zinc deficiency?
Okay, so I'm going to group those together in vitamin C, copper, or zinc deficiencies.
Oh, dang. That's only one?
That's one. So deficiencies as a cause. Where else can you see delayed wound healing in? Twice? And 3 times? Okay. So the other ones are infection and foreign bodies, ischemia, diabetes, other causes. All in there. So, infection is the most common cause where delayed wound healing occurs, and the most common offender. So what organism is most common in
Staph aureus?
Yeah, Staph aureus. There we go. Alrighty, so why is vitamin C important? What is it?
Collagen building.
Yeah, so
Builds collagen.
what step in collagen synthesis is vitamin C a cofactor for?
Is it triple helix formation? Or is it hydroxylation?
Yes.
Okay, so triple helix formation is
Copper?
Yeah, copper.
Copper is important in cross-linking. It's a cofactor for a particular enzyme. Do you know that enzyme? Okay, so copper is a cofactor for lysyl oxidase.
Oh, yeah. Okay, that's the cross-linking.
Which cross-links lysine and hydroxylysine. And then we have zinc. What is zinc a cofactor for? That we already kind of
Collagenase?
Yeah.
Type 3 to type 1?
Correct. Awesome possum. Okay, just a couple more slides, I promise. Dehiscence. Does anyone know what this is?
Opening of an already closed wound.
Yeah. Dehiscence is the rupture of a wound, most commonly seen after abdominal surgery. And what is a hypertrophic scar?
Scar that. I was gonna say a scar that when you experience hyperplasia within the margins of the original wound.
Yes. So you have excess production of the scar tissue and, like you said, localized to the wound. Contrast with a keloid.
It's a lot of type 1 collagen, right? So it goes beyond the borders?
Yes. So that's the difference.
And it's like a... Okay.
So you have excess production of scar tissue, but this one is out of proportion to the wound. It goes outside the borders, and that's crazy. This is characterized by, I know you said type 1. It's both, but primarily excess type 3 collagen. And it is more common in what ethnicity of peoples?
Dark-skinned people?
African Americans. And classically affects what parts of the body?
Face?
Yeah, I see. Face, earlobes, and upper extremities mostly. Okay. So, yeah. There's first aid's little summary of scar formation. As you can see, again, mentioned there, hypertrophic with confined to the borders of the original wound, and keloid, as you can see, extends way beyond the borders of the original wound. And keloid has, like you said, type 1 and also type 3 collagen to a very, very excess amount. Huh?
Cool.
Okay. So last thing is a big summary to all this wound healing stuff we just talked about. We have 3 main phases of wound healing. Can anyone tell me what the first phase of wound healing is and the period of time that it occurs in?
Inflammation.
Inflammation.
Within like the first couple of days?
Yeah, so inflammation, and this is up to 3 days after the wound occurs. So you have your platelets, your neutrophils, your macrophages coming in, cleaning stuff out, calling other things in there, all that fun stuff. And you have your clot formation and all that going on. And then you have your next phase, which is...
I know the last one's remodeling, because you asked that earlier.
The last one is
Proliferation?
Proliferation. And this takes up what amount of time?
Up to a week?
Yeah.
It's like 7 days?
Yeah, so day 3 to a week or weeks-ish. Kind of overlaps a little bit, but yeah. So now you have fibroblasts coming in, myofibroblasts coming in, endothelial cells, keratinocytes, all these guys coming in to deposit tissue and collagen, and then you have angiogenesis going on, proliferation happening, hence the name of the stage. wound contraction, all of that stuff. And then remodeling 1 week to 6 or more months after the wound. And this is primarily fibroblasts coming in here, laying down collagen, and type 3s being replaced by the stronger type 1 to increase the strength of the tissue. Any questions? No? Alrighty then. We are all done.
Yay.